So I farm so hard, the employees wanna find me, and then wanna hire me. What's 100K to a guy like me? Could you please remind me? Farm so hard, this ain't easy. Working late nights, you best believe me. My grades can only go A's. Never wanna see another B unless I'm Jay-Z. Farm so hard, let's get paid.
This is Morgan Grier.
This is Micaela Hayes, and you're listening to another episode of the Pharm So Hard Ambulatory Care Podcast.
All right. Hey, y'all. Welcome back to another episode of the Pharm So Hard Ambulatory Care Podcast. And today we are wrapping up our Women's Health series. And today we're going to be talking about emergency contraception, which is a very important topic to talk about, especially considering all of the legislation that is going around in our country. So I think first to kind of kick it off is to realize how we even got here. So Micaela, walk us through, how Plan B and some of our other options came to be.
Yeah, so this is a really important topic because 28% of reproductive age females report using emergency contraception at least once in their lives. So it affects a lot of people. Emergency contraception, or I'll abbreviate it EC, is a way to prevent pregnancy that can be used after unprotected sex or contraception failure. So we got to think about a timeline here, which is the most important thing to keep in mind with emergency contraception. It may be effective up to 5 days after unprotected sex, and the sooner you take it, the better it works. So keep that in mind when and if you need it. It's important to define that emergency contraception is not an abortifacient. Thus, it will not work if a person is already pregnant. So emergency contraception additionally does not stop the implantation of a fertilized egg or affect a developing embryo. And a study from 2023 found that 73% of people incorrectly think that emergency contraception pills end a pregnancy. So that is not true. And we want to clear that up with this podcast for sure. And Plan B was the first oral product approved for use by the FDA in 1999. So that's a good background. And Morgan, I want to throw it back to you and have you talk about pharmacotherapy options within this emergency contraceptive space.
Yeah, no, I think that's great to kind of clear up, first of all, too, because I think that's a common conversation I have in clinic or with patients sometimes is they're like, oh, emergency contraception is the same thing as abortion. And it's definitely not. They're two separate entities. So want to make sure that we're making that clear distinction with anyone that we're talking to. But as far as our options, we have a lot of options. And I think Plan B and just emergency contraception in general is a lot newer than we think it is. You just said it was first approved by the FDA in 1999. And so probably as long as we've been alive, that's as long as we've even had these options available. So you even think about like our moms, our grandparents, whoever, they didn't have these options available to them. So that's kind of weird to think about. But the first one to come on the market was Plan B. We have a lot of generics or other like brand name options nowadays. Like another popular one is My Way, but the actual compound of it is levonorgestrel, which may sound familiar because that's a very common part of birth control that we talked about in the first part of the series. So that should not be an unfamiliar name to most people. And it makes sense because it's literally kind of like a boosted up dose of birth control. That's essentially what emergency contraception is. And it works the same way that birth control does, which is the progestin component of that birth control, which is delaying or inhibiting ovulation. So that's really how it prevents any pregnancy. But again, it's not going to work if a pregnancy is already established because ovulation has already happened. So there's no way to prevent it if it's already happened. So again, making that very clear distinction. It works by pretty much reducing the risk of pregnancy from anywhere from 81 to 90%. But again, to your point, the sooner you take it, the better it works. So where you fall in that 81 to 90% really is dependent on how soon you take it after, a contraception failure or unprotected sex. But specifically with the levonorgestrel products, you want to do it within 72 hours. So your window is just a little bit tighter when we talk about the true efficacy of the product. As far as side effects, you can have some nausea, headache, breast tenderness, some spotting. And the thing I think people forget to talk about sometimes, but I think is an important counseling point, is that it can cause somebody who's had regular cycles or regular periods to kind of delay their period or miss it in a sense. And in a situation where you want to be sure if you're pregnant pregnant or not, that could be a very scary and even further anxiety-inducing thing to happen to you, because you might be thinking, oh, I take it and then my period and my cycle is just going to be normal afterwards, and that might not be the case. And it makes sense because you're adding, more progestin or different hormones than what you're normally experiencing in your cycle. So just being honest with patients up front that might happen, and to always take a home pregnancy test if they're not sure, and then to always feel free to come into the office if they need that confirmation as well. And then another misconception that people have from emergency contraception is that it could somehow impact their fertility or ability to get pregnant in the future. And that's just not true either. So you could realistically, take emergency contraception this month and the next month be able to get pregnant just as easily as you could the month before. Another oral contraception option that you don't see as often because it is prescription only is ulipristal acetate. This comes in like a 30 milligram tablet. It is prescription only. So this is kind of important to recognize when we talk about accessibility a little bit later on. But when we think about some of our states that we talked about in the last episode that we have pharmacists prescribing of contraception ability, some of those states also have the ability for pharmacists to prescribe emergency contraception. So as of 2022, there were about 7 states that also allowed for that. But unfortunately, in the states where they don't allow that, it could be a little bit harder for people to get access to this particular product. The brand name of this is usually called Ella. I think it's like in a pink box. I know it. I could see it in my brain. But the efficacy is a little bit better with this product versus Plan B. So it's only about a 2.1% failure rate. And you have a little bit of an extended timeline with this product as well. It's up to 120 hours, aka 5 days. So you kind of have a little bit longer of an opportunity to potentially prevent pregnancy after, unprotected sex or contraception failure. However, that does come with some caveats because you have some drug interactions. And then also if you're a breastfeeding mom, you need to be aware of a couple things too. So if you do choose Ella over an option like Plan B, you would have to wait about 5 days before you would be able to start like a normal oral contraception method, because there are some drug interactions basically making the birth control ineffective for those first 5 days after using a product like Ella. So we would want to be able to counsel patients on that if we're talking about like longevity and long-term options for people after using an emergency contraception product. And then if a mom is breastfeeding, they would have to essentially pump and dump for about 24 hours because it's not compatible with breastfeeding and could transfer to your infant if you're still breastfeeding your child. So there's just some things to be aware of if you're thinking about a quicker oral contraception option. But I think the main conversation in these options comes down to weight. So there's been a lot of talk and discussion around, are there weight limitations with emergency contraception? And what this really comes from was a couple of studies done in like the 2010s kind of era. So in 2011, there was a study that came out really comparing the efficacy of oral emergency contraceptions between groups of women who were obese and then who were not. And so really their obese marker was this 165 pounds that you see talked about in a lot of different studies or packaging when it comes to the use of Plan B specifically. And we'll talk about that a little bit. So after that 2011 study came out, there was also 2 pharmacokinetic studies that essentially supported a similar theory that there was some association between obesity reducing the bioavailability of emergency contraception in women who took it. So again, for Plan B, that was around 165 pounds. And then they looked at Ella as well, the ulipristal, and that was increased up to 194 pounds. So again, if you're closer to that 194 pound range, maybe the Ella, you wouldn't have as much of a concern as you would for like a levonorgestrel product. And I think this is important to discuss and, have further research about, because the CDC has come out with reports that says the average American woman weighs about 171 pounds. And so that means the average woman would fall into the category of somebody who would be affected by this product potentially not working for them simply based on their weight or where their BMI fell. But what I think is interesting is that in 2016, the FDA came out and made a statement, and they said there's really no evidence that emergency contraception pills are less effective for women with a higher BMI or higher body weight. And also that there was no genuine safety concerns because of the weight restrictions either. What they did say was that based on a review of the scientific data that was available, aka these other studies that kind of started the conversation, that they found this data to be inconclusive and often conflicting with one another. And so what they really did know and push was what we were saying before, that the most important point of these products is being able to take them kind of sooner rather than later. And that's the more important factor rather than a patient's weight and impact on how well they're going to work for our patients. Now, we do have some other options that we don't see as often either. One of my favorite ones that people don't know about as much because we typically don't use it a lot is actually there's some evidence that your regular contraception that's a combination product could be used as emergency contraception. And that goes back to the same mechanism that we talked about with like the Plan B option, is that it's essentially a boosted up birth control dose. So there is certain types of estrogen and progestin containing products that could act as emergency contraception when taken in higher doses, which is almost 4 to 5 times the regular like birth control dose. Usually you see this as like 2 tablets spread apart across 12 hours. So there is some evidence to say that that could be done, but of course we wouldn't want a patient just going off and doing this on their own. We would really recommend you consult, your healthcare team to make that decision and discuss, how exactly you should go about it. And if your birth control option is even an option for that. Again, there's only certain types of estrogen and progestin containing products that could be an option for, because we've already talked about in the rest of the series how there's different doses and different types of products. And so really making sure that your birth control is an option to be able to use it as emergency contraception if you actually really did need to. And then our last option is going to be specifically what originally came out was the copper IUD. So another great option for people who maybe also want a more longevity option after needing to use it for emergency contraception, because that's a big part of this discussion as well, is not wanting to always resort back to emergency contraception. What's going to be our long-term plan after this? So it works the same way that it does for birth control, which is preventing the sperm from getting to the egg and thus preventing fertilization as a whole. It has a 1% failure rate, so works really, really well. And this could be a great option for people who either want to avoid hormones as a whole, or if they're concerned about the efficacy of somebody with a higher body weight or a higher BMI, this could really be an option that's maybe more secure in their head, that they're comfortable is going to absolutely work for them. There is also emerging evidence that says Mirena and Liletta, so our hormonal IUD options, could also be effective as an emergency contraception option. So that we're getting more and more information about other options besides just our original Plan B that's going to be available to women.
Yeah, that's so awesome. 3 points stood out in my mind when you were talking about all these things. Number one, I'm sure that most American females or most women in general are not aware that emergency contraception could be weight-based, and that's a factor. And then number two, that birth control could be used as emergency contraception, the birth control that they're on. And then number three, I just wanted to reiterate that the copper IUD is coming back for the win yet again. So it's just like coming up in my mind over and over. But those are amazing points, and just it drives home the point that we need to discuss emergency contraception and this topic with each other and with our healthcare providers to make sure we're making an informed decision about it.
Yeah. No, the birth control one is my favorite fact. When I taught this to a couple of pharmacy students last year, they were like, wait, it can actually be used as emergency contraception too. I was like, yeah, it can, but don't just like go saying every single one, because it has to be like specific ones of specific doses and stuff like that. But technically, yes, it could be, because that's really all emergency contraception is. And you see the overlap here, right? Like a lot of the things that we talked about for regular contraception came back for emergency contraception. So I think it's really cool. And I think we're going to continue investigating a bunch of different options for emergency contraception. And I mean, one thing I forgot to mention with the oral emergency contraception is they're one dose. There used to be options where it was like 2 doses, 12 hours apart, and maybe you had to take it over several days, but now it's just one dose, and that's kind of it. And you can move along with the rest of your life.
Yeah, that's so, I guess, convenient. And the fact that it's been around since we've been alive basically is pretty awesome. I love it.
Yeah.
All right. I think I'm going to move into the safety and consideration factors with emergency contraception. So, the first one we're going to talk about is cost barriers. So, if you pay cash for emergency contraception, it is about 10 to $50 depending on which one you select, and the brand name Plan B does have a $10 coupon, and IUDs can be even more expensive. So I talked about the IUD coming in for the win, but it might not be a win in your wallet. So that can be between $500 and $1,300. So you definitely want to weigh what is most important for you and what is best for your specific situation. And again, I can't stress enough to discuss it with a healthcare provider who knows all the ins and outs about the data and what is best for you. Emergency contraception or contraceptives could be covered by insurance, but it would require a prescription and could possibly require a clinic visit. The Affordable Care Act requires emergency contraception to be covered under most private health plans. And then most state Medicaids have required family planning services that include coverage with emergency contraception with a prescription. There is an increase in online platforms such as Nurx that can ship medications to the patient's home, but it may take some time. So remember how I talked about at the beginning and Morgan discussed, there are time factors involved with this, and they can be, the sooner that you take it, the better. So we want to keep that in mind if you're getting it shipped to your house. And then another barrier, our second barrier that we're going to talk about is the legislation blocking access to EC or emergency contraception. So prior to 2006, a prescription was required for oral EC. And then from 2006 to 2014, emergency contraception was available without a prescription, but anyone under 17 did need a prescription. And then there was previously a minimum age requirement for emergency contraception, but then it was previously removed by the FDA. So that was a win there. And then post Roe versus Wade, we have many states that are lobbying for Medicaid to be excluded from coverage of emergency contraception. And Texas was successful in 2020, and it will be reevaluated in 2024. And Missouri did attempt to go along with this as well in 2021. The third barrier is going to be, or safety and considerations that we need to think about, are long-term contraception. So most patients go to the pharmacy for emergency contraception, and if that pharmacy also allows pharmacists prescribing of contraception, we could be preventing future unplanned pregnancies and really helping to open up the access to care for our patients. I know as a patient trying to get into an office appointment, it's months before I can get seen unless there's an issue that speeds things along or a spot opens up, and rarely that happens just for me as a patient. So I think pharmacists being able to prescribe long-term contraception really helps to provide access to a lot of patients and can help prevent unplanned pregnancies, giving this option, especially in this time crunch period. And then there is no limit to how many times you can take oral emergency contraception. So don't think that, I did it this month, I can't do it anymore. I need to be careful. Like, it is like birth control. It doesn't affect fertility, and there's no risk for how many times that you take it.
Yeah, no, I think those are all great points. And I think it's a fine balance, right? Like, there's no limit on how many times you could take oral emergency contraception, but really also trying to talk about those long-term contraception options, because we want them to be protective for any future encounter that they're ever going to have, not just this one individual encounter. But I think as we go forward, really talking about, the legislation potentially blocking access in some of maybe the more conservative states throughout the U.S. We talked about Texas and Missouri, and there's other states who have pending legislation, or they're trying to uphold certain legislation to block access to emergency contraception. And as we talked about, there's time limitations on emergency contraception. And so really making sure that these products are going to be as accessible as possible, and with you talking about clinic visits are potentially very difficult to get a hold of. You would obviously need a clinic visit for something like a copper IUD to use that option. Some people might require a clinic visit for a prescription product like Ella, so where pharmacists can really step in and play a role in this space is really important to discuss. And especially in the states that already have pharmacist prescribing of contraception in general, why don't we add the emergency contraception component to that legislation? It seems like a very easily identifiable area for pharmacists to play a role, even though some of these options are OTC anyways. Like you can easily say, oh, Plan B is already OTC. Why would a pharmacist need prescriptive authority for, this? Well, I mean, maybe the person wants to go with Ella because it has, that only 2.1% failure rate, or the fact that it technically has some evidence up to 194 pounds versus 165 with Plan B. And a patient might be genuinely concerned about that, but they can't get into their OBGYN office or their PCP office. How can we further decrease any barriers that are going to be for a patient in any scenario? So those are always going to be important things for me to have on my forefront.
Yeah, that's awesome. That's a great conversation for everyone to have in the pharmacy space, to just open it up and see if we can help our patients and help expand access of pharmacists and what we can do to help our patients.
Yeah, so I think in summary, really just talking about emergency contraception, it's only intended for the use after unprotected sex or contraception failure, and really shouldn't be used as a regular method of birth control. When it comes to the weight and all of the oral emergency contraceptions that we have, the evidence isn't entirely clear. Also, that we do have some evidence to say there might be an association between the efficacy of oral contraceptions and then the weight of the user. Again, the FDA has really come out and said that further research really should be done by these manufacturers, and it should be a priority for them to get to the bottom of, is there actually an association between the weight of the user and the efficacy of the product? So really keeping these things in mind when we're talking to our patients in the community setting and the clinic setting, and providing them all of the options that they have.
Yeah, and I can't stress enough for patients to consult with a healthcare provider for personalized contraceptive advice. And we have another episode in this Women's Health series, or is this the last one, Morgan? You remind me.
This was the last one.
This was the last one. That's what I was thinking. So
it was the last one.
We are finishing up our Women's
Yeah.
Health series. I hope you guys have enjoyed it, and, join the conversation, leave us a comment, subscribe so you never miss another series or episode with us again. And I'm sure we're going to be doing some more series soon. So keep checking out what's new with the podcast, and we look forward to having y'all soon. Thanks, guys, for tuning in. And don't forget to just keep the conversation open to help expand the access of the pharmacist and, keep killing it in the ambulatory care space. And until next time, we'll see you on the Pharm So Hard Ambulatory Care podcast. Thanks, guys.
So I farm so hard, the employees wanna find me, and then wanna hire me. What's 100K to a guy like me? Could you please remind me? Farm so hard, this ain't easy. Working late nights, you best believe me. My grades can only go A's. Never wanna see another B unless I'm Jay-Z. Farm so hard, let's get paid.
This is Morgan Grier.
This is Micaela Hayes, and you're listening to another episode of the Pharm So Hard Ambulatory Care podcast.